Okay, well, I think we're going to go ahead and get started. Thank you all for coming to the Diagnostic Conference. Today we are going to talk about IV fluids. For any of you who might not know me, I am Dr. Roche, the hospitalist here. Okay. So IV fluids. There is a lot to know about IV fluids, although there are not really any definite answers to a lot of questions about IV fluids either. There's no perfect IV fluid, but this is kind of the history where IV fluids came from. So there was a doctor, Dr. Thomas Latta in Scotland, who back in 1832 there was a cholera epidemic and everybody was dying from this horrible diarrhea, vomiting, just losing fluid, becoming very severely dehydrated, and no one could stop it. And Dr. Thomas Latta used IV saline in order to save some of these people. And he wrote a letter to the Lancet, and it was published June 2nd of 1832, talking about how he was doing this. And this was how he described one of his patients. He said, "At first there is but little felt by the patient, and symptoms continue unaltered, but the improvement in the pulse and countenance is almost simultaneous. The cadaverous expression gradually gives place to appearances of returning animation, and the livid hue disappears. The warmth of the body returns, and in 48 hours she smoked her pipe, free from distemper." So she was healthy enough to survive to smoke again. Hooray, right? So this patient that he described here, she actually did survive. She received about 9 liters of fluid over 12 hours. That's quite a bit, right? So unfortunately then Dr. Latta ended up dying of pulmonary TB about 18 months after he saved all these people. So, and then it did take actually quite a long time for IV fluids to then become popular and common practice. By the end of the 1880s, they had it being used a little bit more, but it really wasn't until the 1950s when it really became available for normal use. And now we certainly use it on a daily basis in the hospitals and everything today. So this is a picture of IV infusions being given in Scotland, where Dr. Latta worked at one point at Edinburgh Royal Infirmary, and that was in the 1970s. Okay, so the human body takes in fluid in a couple different ways. Of course, we're all eating and drinking, and so we get most of our water intake from food and liquids. And then our cells make a little bit as well. And then water is lost from the human body in a few different ways as well. You can see there urine output is the biggest way that we move water out of our system. And then from the intestines a little bit as well, lungs and skin a little bit as well, but most of it is urine output. So that's kind of one of the reasons that we watch urine so closely when they come into the hospital and are sick. So total body water. A person has an awful lot of water in their body if you think about it. We are made up of mostly water. And so this just kind of gives, it's complicated and all, but the intracellular space, so inside the cell is 40%, and then extracellular, which is where the blood vessels are, all the fluid in the blood vessels, intravascular or plasma volume. And so I wrote down the calculation there. When you figure it up, if a person, let's say that first guy at the top is 70 kilograms, so our typical standard patient, 42 liters of water in that person. So that's quite a bit of water. Now a liter, which I had to look up, but it does weigh 1 kilogram, which I guess that makes sense, right? So anyways, the plasma volume for that guy would be about 3.5 liters. So then, for more like our typical patient, that might be more like 100 kilograms. It's kind of moving more in that direction, but they are 60 liters of water, and then their plasma volume would be more like 5 liters. So here are the different electrolytes. There are lots of them in our body, but there are a few that kind of take over, and that's why we see them trying to be recreated in IV fluid, so that when we give it to our patients, that it's as much like body fluid as possible. So you can see the extracellular fluid is the most important, because that's what's in the plasma volume. That's what's inside of the blood vessels. And so sodium is the main component up there, and it's about 142 milliequivalents in a liter. And then the chloride down in the box below that, 103 to 105. That's as much chloride as we have in a liter in our bodies. And then there's all these other little ones, potassium and magnesium and phosphorus and bicarbonate, all those things. So there are a lot of different kinds of IV fluids. As you can see, there's lots of bags on the table here. And these are all different ones that we have in our hospital available. They might not all be on here, but the most common ones that we use, and there's a couple up here, half normal saline, we hear this stuff all the time, LR, D5LR, and most of us kind of have an idea at least of what might be in them. But if you do look at the bag that happens to be in front of you, you'll see that it really does tell you exactly how many milliequivalents of each electrolyte is in there. Per liter, yes. So this is a 1 liter bag. Pretty much all these except for this one little potassium thing here. But, so
actually, most of the listings on there are listed per 100 mils.
I see that.
And there's a reason for that. It's because that's the easy way to figure percent. Like 5% dextrose is 5 grams in 100 mils.
That's old chemistry terminology.
Right.
And it's not really percentage.
No, it's just near as it can get.
Yeah.
So what I have listed up here is more, these ones are in 1 liter, I believe, correct? The 150, like 154 in normal saline is 154 milliequivalents, I think, per liter. Is that right? Yeah, sodium and chloride. So if you remember back here, now sodium in the ECF was 142 and chloride is only 100, or 103, 105. And so the sodium chloride, 154, it's a little bit more than the sodium in ECF, but similar. And then you can see the chloride, it is a little bit higher. That was only 105. So some, we'll see it a little bit. You do get into trouble every once in a while if you're giving a lot of volume of fluid. With normal saline, you'll get a hyperchloremic state, and that can cause some problems. So, but then you have half normal saline. You can see it's about half. That, and there are different types. The isotonic ones here are the normal saline. Isotonic is lactated ringers, or LR. And isotonic basically just means it's similar enough to the ECF or to the plasma volume that the fluid, there's not going to be a big fluid shift, hopefully. The water doesn't try to escape from the blood vessels or doesn't rush in to the blood vessel from the extracellular area. And then you have hypotonic and hypertonic, and those basically refer to the amount of electrolytes that are in the fluid compared to what's in the plasma, and so, or in the ECF and things around it. And so depending on which one you use, you may have fluid rushing into the plasma, so it might expand your plasma volume, which is good in people with hypotension and things like that, shock. Or you might have it so that all that water or fluid that you're giving is seeping out into the tissues. So you got to be careful with using all these different things. So, and then there's a lot of the D5W and D10W. Those are what, like what Don was referring to. You get your 5% dextrose. You have 5 grams of dextrose in there. So you can give just free water, or you can do that. We use D5 and D10 in order to give sugar to people who might have hypoglycemia and things like that. So, several different kinds. Now, there are colloids as well. Does anybody know which ones are colloids? What might you say would be a colloid? Besides, instead of a crystalloid, which is the fluids that we've been talking about, the ones that we have here.
Dextran.
Yeah, dextran, that's one of the synthetic ones, more famous kind of thing. That, yes, albumin, that's right. Any kind of blood product as well. So here you have your blood products, packed red blood cells, albumin platelets, FFPs. We do give these things from time to time. And then there's the synthetic products down there. There's semi-synthetic that use starch and those type of products to try to, these are plasma expanders. They're meant to be, expanding the fluid in the blood vessel. That's the idea, is to try to keep people from going into shock and having the hypotension and or
They still use dextran? Is it actually That's still used, Steve?
The dextran?
Yeah, D40, D70, or dextran 40, dextran 70, based on the molecular weight.
No.
Not as much anymore, but still.
Not here.
All of those things, from what I could find about them, and we don't really use them here much, but I don't know that we even have them here available, but they're more expensive, certainly, than the normal saline and LR that we use. And they do have other side effects for people as well, so some of them are not as popular. What do we use IV fluid for? Stephanie, what do you guys use IV fluid on the OB floor for? Dehydration.
We use it to get people who qualify for Medicare.
We use it to get them for their insurance to pay for them to be here. Yes, we have to have intensity of service. What kind of things would we use it for? Lori, what do we use it for up on 2 South?
Well, dehydration. If their sugars are low, we might run that.
Glycemia.
Yeah. That's it.
Very good. Good. So I put up there sepsis as well. We use it for sepsis. We use it for DKA. We use lots for those things. Dr. Branch uses it all the time, right? Perioperatively, and so if they have acute blood loss, we might use it. We might be more likely at that point with their acute blood loss to use the colloids that we talked about. But then for shock, hypoglycemia, like Lori mentioned, and then sodium issues as well. They're hyponatremic or hypernatremic, depending on what the cause is, which could just be dehydration. So we use it for all those different things. Now, so we want to give a bolus of IV fluid. So we're on 2 South. We have a patient in sepsis, and their blood pressure is dropping drastically. We're going to give them a liter bolus. What do we like to give them? What do we generally use? What kind of fluid would we use safely? Normal saline or LR, as Stephanie said. Yep. And those are the main ones that we would want to use for that. Now here I just put up kind of a guideline. Kids and adults and newborns all get slightly different amounts for a bolus. And this is kind of the typical. For an adult, this is a very aggressive bolus, but it's for like, sepsis is what we would do in early goal-directed therapy. We give 30 mLs per kilogram. So for a typical 70 milligram patient, or 70 kilogram patient, when you calculate that out, it's around 2 liters. So that's why we often say, okay, they're septic, we're going to give them 2 liters. That's where we come up with that number. And then for pediatrics, 20 mLs per kilogram is what's in the PALS, when you guys take the PALS course, that's what we talk about giving. And for neonates, it's normally a 10 ml per kilogram, so smaller amount depending on what size your patient is. So then for maintenance IV fluids, that's different than bolus, right? So when I was in medical school, I was working at a pediatric hospital doing a little rotation in pediatrics, and I suggested that they give a bolus, but instead of giving the bolus in normal saline or LR, I said, oh yeah, we do the D5, quarter normal saline with 20 kcal, and we give a bolus of this, and they were like, please don't kill any of our patients. And I said, oh, why? What's wrong? And that's when I learned and have never forgotten that a bolus is always, you want something isotonic. You want it to be normal saline, LR, those are really your main choices. So then, the D5 quarter normal saline and all that was great, except that's more the maintenance fluid. So maybe this patient is NPO for whatever, they can't eat, they have an NG tube or some other thing going on, and they're not going to be able to eat. So this 4-2-1 rule, there are, if you look on Google for how do you calculate a maintenance rate, there are 8 billion different ways that come up for adults, for kids, for newborns, all kinds of different things. But I think the 4-2-1 rule is really one of the most simple ways, and you can use it for adults too. It was I think mainly a pediatric thing to start, but so you can see here the 50 kilogram kid, you have to calculate it out for the first 10 kilograms and the second 10 kilograms, then the whatever's left over, and so that ends up being about 90 mLs per hour. So if you need to give that kid maintenance, you can do it like that. And then you can see for the adult down below, 70 kilogram person, well that's not really that much more than the 50 kilogram child would get. Although 50 kilogram child is rather big kid, but around 110 mLs per hour, which incidentally is a lot, very close to what we use often here when they first come in. And it's not really a bolus, but it's not really maintenance either. It's like our attempt to rehydrate them gently, because we get a lot of elderly people. We get a lot of people who maybe they haven't eaten for a couple of days, but they're not they're not septic, they're not in DK, they're not somebody we need to be extremely aggressive with. They're not hypotensive or anything. They have a little bit of a renal insufficiency, and they haven't eaten and drank for a couple of days by their history, and so